Hello students, I am Dr. Sachin Budhiraja. I'm a practicing consultant of medicine and a teaching faculty and editor of this wonderful book on ENT, that is ENT for entrance exams. Today I would like to teach you another very important concept in medicine, and let us solve this question, and after solving this you will be able to imbibe this very important concept, right? Okay, so the question says that we have a 14-year-old boy who presented in the OPD with frequent urination, increased thirst, weight loss despite increased appetite since few weeks. There is no family history of diabetes. On examination, his vitals and general systemic examination are all normal. And considering the history, frequent urination, uh, well, uh, you all must have heard of this polyuria, polydipsia, increased thirst history is also there, and weight loss in a patient of diabetes mellitus. So just a little information here that frequent urination is different from polyuria. If you recall, in the previous video I talked about that polyuria is actually if the volume of urine in 24 hours is more than double the normal, that is if it is more than 3 liters, then you say it to be polyuria. But for the timing, you may consider that it is likely polyuria only. Polydipsia is there and weight loss is there despite increased appetite. So that is why you have ordered this fasting blood sugar, postprandial sugar, and an HbA1c tests, and these were reported to be 250, 350, and 9.5% respectively, right? So the sugars are clearly high, but you should know, what are the normal values and when do you call that the person is suffering from diabetes. Well, this is something important to know. So you need to remember this, that fasting blood sugar, that is after 8 hours to 12 hours of fasting I'm talking about. So this sugar should be typically less than 100, but we call diabetes only once it goes beyond or touches 126 milligrams per deciliter, right? So this is when you call the person is having diabetes. Similarly, another test you advise is postprandial. Like this is typically done, after giving 75 grams of glucose, say dissolved in around 300 ml of water, right? And after giving this much glucose, so 2 hours later you get the pp test done. So again, normal value is less than 140, but if the values go beyond 200 or touches 200, then you say that the patient is suffering from diabetes, right? And the third test we advise is this HbA1c. So this is glycosylated hemoglobin, and this gives us an idea of the sugars of the past 3 months, right? And here again, the normal value is less than 5.7, but if it touches or goes beyond 6.5%, we call it diabetes. So these values should be remembered: fasting more than or equal to 126 milligrams per deciliter, postprandial more than or equal to 200 milligrams per deciliter, and HbA1c more than or equal to 6.5%, and we label the patient as having diabetes, right? So in that question, if we see the values are clearly in the diabetic range. So this boy is suffering from diabetes, right? And subsequently you asked for this anti-GAD. uh, GAD is glutamic acid decarboxylase. GAD65 antibodies done, and you found it to be present and elevated, greatly elevated. Okay, so we'll talk about this. Which of the following is true? So, with our history and then subsequently the sugar testing, it is clearly a case of diabetes, no doubt about it. Okay, so which of the following is true? Get his fundus examination done to look for diabetic retinopathy. Hmm? Is it true? Get AC ratio, this is albumin to creatinine ratio in early morning spot urine sample. Okay, so examiner is asking about that, screen this patient for microalbuminuria. Well, and then both A and B should be done. Both A and B are not required at present. So what should be the answer? Well, some of you might be thinking that diabetes leads to retinopathy. In fact, this is the most common systemic condition to cause blindness. And we have done in our previous lectures that in our previous discussions that diabetes lead to CKD most commonly, right? So we need to screen for microalbuminuria as well. So many of you will say the both A and B should be done, right? But the answer to this question is that both A and B are not required at present, right? So D is the option. We do not want to get fundus examination done as well as microalbuminuria testing done presently. Why this is so? Well, retinopathy and the nephropathy, these are microvascular complications of diabetes, right? And these are long-standing complications, right? Now, the case which we are dealing with, a young boy, and he's presenting with polyuria, polydipsia, and weight loss. So this is, a classical presentation of type 1 diabetes. So this is suggestive of type 1 diabetes. Please remember that type 1 diabetes is a very prompt kind of diagnosis. It is a very early kind of presentation. Type 1 diabetes typically happens in this age group, say from preschool age group to the pubertal age group. This is the maximum. This is the age group typically, maximum patients of type 1 diabetes present in. So, 14-year-old boy near puberty and presenting with all these things. So, and another important thing is that there is no family history of diabetes. And if you recall, in my first video, I told you that, family history is positive typically in type 2 diabetes, not in type 1 diabetes, right? And then what are these anti-GAD65 antibodies? So if you recall that day also I discussed that this type 1 diabetes, type 1. So with 1 you need to remember that here we have a one pathophysiological mechanism, only one pathophysiological mechanism, and that is here we have an autoimmune destruction of the beta cells of islets, right? So here we have the antibodies against these islet cells, and we have so many antibodies in these patients: anti-islet cell antibodies, insulin autoantibodies. But the most sensitive of these antibodies, which are positive in maximum number of patients. That is why we say the most sensitive of these antibodies is these anti-GAD 65 glutamic acid decarboxylase, so anti-GAD65 antibodies. So this boy ultimately was found to be having anti-GAD65 antibodies. So it's clearly a case of type 1 diabetes, right? So since type 1 diabetes is a prompt diagnosis, it's an early diagnosis, and microvascular complications, they are long-standing complications, arising in uncontrolled diabetes. So therefore, you need not screen this boy right now for retinopathy as well as diabetic nephropathy. So when will you ask for this investigation? This is a separate question asked in your vivas. So you need to know that, see, typically in type 1 diabetic patients, we need to screen for retinopathy and nephropathy after 5 years of diagnosis, right? So once the child will be, 19, then you'll be asking for these investigations, right? So answer to this question is that both A and B are not required at present. Okay, so let us see another case scenario. So here we have a 42-year-old male who presented in the OPD with fatigue since the last few months. He's overweight. His BMI is 28, right? So you all know that Well, so you all know that, as per the BMI, which is weight in kgs divided by height in meter square. So normal BMI is 18.5 to 25, and we say overweight once the value is between 25 to 30, you call it obesity once it is above 30, and if it is below 18.5, you call it underweight, right? So as per the BMI, this female is yeah, the previous question. Yeah, so this male is an overweight person, and he's a physically inactive person, working as an executive in a private company. Family history of diabetes is positive in both the parents as well as in the elder brother. And again, you have advised him to get fasting blood sugar, postprandial, and an HbA1c test done. So you were right, in ordering these tests, because this is a classical presentation of type 2 diabetes. uh, Type 2 diabetes is mainly asymptomatic to begin with. At times, the only symptom reported is this non-specific fatigue, right? Why? Because in type 2 diabetes, the hyperglycemia is very slow and gradual to begin with, right? And therefore, no symptoms, or as I said, maximum this fatigue, which is happening to these patients, right? And type 2 diabetes is typically seen in adult age, 40 or more than 40 years. And as we have done, that family history of diabetes is typically present in type 2 diabetes. So again, the sugars are clearly high. We know the normal values. So the same question, get his fundus examination done to look for diabetic retinopathy, screen for microalbuminuria to rule out diabetic nephropathy, and both A and B should be done. Both A and B are not required at present. So in this case, the answer should be both A and B should be done right now only. So why, in type 2 diabetes, we want to screen for a retinopathy as well as retinopathy as well as nephropathy, because type 2 diabetes, as I said, is a late presentation, and therefore we do not know, maybe the patient has already developing these microvascular complications. So we need to screen for these right now.